funny. I know that. You know that. All right. This is 13D. I sent you my presentation to start muscles that I owe you. I don't even know if I'm going to find a way to test you on that. Maybe you have like a take-home assignment for layout. That's what I was thinking about, just for helps the grades. So this is basically it. I want to look at this first because I want to do cranial nerves. So nerves, effectively, cord is the right way to express it, to describe it. It's an organ of the peripheral nervous system. So anything that projects from the spinal cord or from the brain itself it's part of the peripheral nervous system. We'll get into the definitions. So the nerves are the conduits, basically the structures. Cranial nerves, as they emanate from the brain, okay, and peripheral nerves, if they emanate from the spinal cord. They can have myelin or not. And so what's interesting are the coverings. You're going to see this when we do muscles a little bit. And I do more of this in physiology of muscles because I think it's more relevant. You have something that's directly around the nerve. And so we use the term neurium around, basically endo, loose connective tissue, just a very loose areolar connective tissue that's around the axons, the actual nerve where the nerves are being transmitted. And their myelin sheath that also protects that. You have something called fascicles, which are bundles of these individual nerve fibers or axons. And then and that's perineurium, and around the whole nerve, the part that implies some toughness, okay, is the epineurium. And you're going to say it's with muscles. You're going to have endomysium, perimysium, and epimysium. And so this is what it looks like. What's unique about this is the blood vessels in the middle. So what you're seeing here, and it's a nice cutaway, this would be a fascicle, a bundle surrounded by a particular connective tissue we call perimysium. And then here are the individual axons. So you can see a nerve is comprised of hundreds, if not thousands, of axons. And those are the functional units. And again, they can be very long. They can be a meter long. Again, think of somebody who's 6 feet tall, 2 nerve circuit, head, brain, lumbosacral area to big toe, for instance. And so this is the schematic you always see. What's unique is the blood vessel is external. In muscles, the blood vessel rather is in the middle. In muscles, the blood vessel is more exterior. So here you can see the bundles. And now, when we get down to the individual axon and the myelin sheath, that's really, when you talk about a nerve, sometimes we erroneously were referring to an axon. Because a nerve can be more than that. As you're going to see, when you look at the sciatic or the femoral, they've got branches that go to multiple different structures. So they innervate more than one thing. And so this is just the sort of the gross general anatomy. And again, most of them are called mixed. A mixed nerve means it has both motor and sensory elements. Nearly every motor nerve going to a structure has little sensors. Those are those proprioceptors when we talked about the cerebellum. So I move my arm. You're moving your arm, whether your eyes are open or closed. Proprioceptors. You know if you're pointing. You even know where you're pointing. So there's sensors, even though it is mostly a motor structure. So a mix means sensory or incoming or afferent, and motor are outgoing or efferent. And I always, again, use that pronunciation. It eliminates a certain amount of sort of a vague way of doing it. It eliminates error to me. I was just doing this with all 3 of the A&P1 classes, abduction and adduction, because they got to learn that stuff, particularly for clinical. And it's like, really? It's like, yes, this is what you do. They are relatively rare. I don't even know of a motor nerve off the top of my head that's pure. They used to think the cranial nerve that was purely sensory, okay, was for balance and for hearing, but we know there's a motor component now. And so erroneously, some of these that are just, when you have loud sounds, how you could have an auditory adaptation, or if you're on a roller coaster, or you're on one of those where the floor falls out. I don't do those anymore. We love roller coasters. Just saying, it'll be like that. So again, we'll take a look at whether they are. And again, clusters of the cell bodies. That axon's very long. Cell bodies cluster together, and this we call them, since they're outside the central nervous system by definition, they're ganglia. If they're in the interior, we call it, and then we use the term nuclei. And so that's all part of it. The dorsal root nuclei ganglia. Remember, I showed that to you when we looked at the spinal cord, and that's important for a variety of reasons. And then autonomic is a kind of an oddball. We do that comparatively early. I'd say around this time. We do cell phys, we do muscle phys, nerve phys, and so probably about this time in the spring we do that. Okay, they don't divide. If they're damaged, if it's in the cell body, which is effectively the nucleus, if we think of it in a cellular structure, or close to it, big trouble. Okay, it may die as well as other neurons that are within its circuit. The cell body or damaged nerve is intact. The peripheral axon may regenerate. That's why when we have a severed limb, it's sharply severed, handled properly into a facility, a hospital that has the trauma center they'll have a team that will be a reimplantation team. Like when we were under instructions at that time. Now that's all part of Drexel in Philadelphia. At that time, if we got a severed limb or hand or finger, we were to contact. We had a contact in the hand service at Hahnemann, which was a medical school of its own, but later became sort of bought out. Drexel basically grabbed a lot of peripheral nervous schools, not named Temple, Jefferson, or University of Pennsylvania, and Philadelphia, and it became women's medical, all this. There were a lot of different ones that became all part of Drexel when they began to expand in that area. So again, regeneration does not occur in the central nervous system at all. In the peripheral nervous system, so effectively you're in the axon. They might show you a little bit. So the CNS fibers don't. Okay. Interestingly, when we are going to learn about what are called the oligodendrocytes, they're supportive tissue and they inhibit the growth. Again, we learn about astrocytes, they play a role. So it's not something I'm going to ask you about. But you're going to be able to look back at this when you hear about the physiology. So there's lots of things that you can try to do, okay, with different kinds of treatments. At this point, I'm away from that, so I don't know what the state of the art is. We learned about actual nerve growth with something called nerve growth factor, NGF, and all of these growth factors are relatively new. I recall going to a seminar at Hershey Medical Center. We had a surgical seminar there every year, and one of the docs from Penn State Medical School, one of the docs get up in front of us and he's like, I have some really exciting news that we've been looking at over the last 5 to 10 years that we can present to you now. And they're showing us, in the old days, we would basically sew the ends of the nerve together. Didn't have to do that. All of a sudden, you can actually take the two nerve endings, and as long as they are in close proximity, so they were having these almost like biodegradable or biocompatible sleeves. You put one end in and the other end in, and they would seek each other out because when they're cut, they stimulate a chemical called nerve growth factor. And what it does, and they come together. I saw this clinically. I had a patient who came, I did a bilateral procedure, both feet. One side fine, other side, I can't feel it over here, wherever the surgery was. And I'm like, well, let's give it some time, because I knew that sometimes these things came back. I mean, maybe a year later, I followed up. She's like, oh, you're a miracle worker. I got all my sensation back. Listen, it's just tincture of time, as we call it. It took nerve growth factor, allowed those ends, and it'll grow through anything. It's the reason we have problems with phantom limb pain. It's the reason we have something called stump neuromas, where trapped nerves when you have to do an amputation. And I mean, it's fascinating, really, to stop that from happening. We used to if we wanted to stop it when we did an amputation, we'd bury the nerve endings into bone or into muscle, sew them in there, just so they wouldn't try to grow and find another nerve. It's very interesting. That's it. So these axons, if can regenerate, you don't have to go through it. Just look at the slides. Okay. So distal or away, going away from the injury spreads down the axon. It gets gobbled up by scavenger cells, and then they form a natural tube. I was talking about one that we had created medically or scientifically in the lab, and be able to regenerate. They have neat pictures. We had different terminology, but effectively, here's where the damage was. Maybe it was severe injury, that kind of a thing. Maybe there was a traumatic injury, per se, a cut that cut through that particular nerve, like a surgical cut. And then this is what would happen. They seal themselves off, okay? The myelin sheath's degenerated. They call it a fancy name, Wallerian. You don't have to know. And then the macrophages cleaned it out. And you notice what's happening. And you're going to learn about these Schwann cells. They're the ones that make the myelin play a role. So as you can see, I went too fast. The Schwann cells stimulated chemicals that allowed division. And then the Schwann cells release growth factors. Those are those nerve growth factors. There's other growth factors. We talk about in physiology. There's something called, in wound healing, we use something that comes from platelets called PDGF, platelet-derived growth factor. Sort of that's the framework. That was the critical chemical that was able to be, that's comparatively easy to isolate, that's used a lot in wound healing centers. Wound healing centers, they built so many of them, now they're kind of closing up. It's another story entirely. And here, the cells line up, the regeneration tube, blah, 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 blah. And they then seek each other out, and voila, the nerve heals. But you can accelerate that process, okay, in a surgical sense. So, and I'll tell you, this is a great anecdote because the surgery didn't work. Because it's all about what you're supposed to do. If someone has a severed part, carefully, you try to get that in you basically put it in, if you can get distilled water and a pinch of salt, you try to create some amount of saline solution in a plastic bag and put that plastic bag in an ice bath with water and ice. But you don't want direct ice because that will damage it. So we had a case where a guy came in, he was working, you'll love this. He was working at Seal Test, dairy company, made ice cream out of Philadelphia back then. And he's working in the dairy, making butter, in a machine that makes butter into quarters, the typical butter stick that we're so familiar with. He got his hand caught in the machine, like to here, and his middle finger got amputated sharply by the butter machine. And in comes, we're stopping the bleeding. I mean, it's not going to. He probably wouldn't have had to lose his job or anything. I'm sure he did, because there was not going to be a big functional loss. In comes one of his buddies 5 minutes later with a block of butter, like a pound of butter, and guess what? The finger's in there. So we tried to re-implant it, cleaning off the end, but the fat on the butter really was a problem. And what the doctor said, because it was sort of distal phalanx, it was kind of behind the nail. First thing he said when the orthopedic surgeon came in, and he looked at it, we had done that in the emergency room with the emergency room doctor. Basically, it became a biological dressing. He said, "Did you pull out the bone?" And we went, "No." He said, "You should have pulled out," because that fat on the bone was never going to take. So eventually, it necrosed, and it healed over with scar tissue. And basically, I mean, there's no problem with function. It's just like the middle finger was a little bit shorter. But I mean, when it came in the butter, it was just hysterical. Could you imagine that going out to somebody? Go over to the grocery store. Hello. Everybody's got those. The cranial nerves. I sent you a recording about those, but it behooves me to try to get through it. I'll try to get through it expeditiously. This is one of those tests of memorization. There are 12 cranial nerves. We use Roman numerals. You can use regular numbers. Don't care. And figure out a mnemonic. That's the best way to do it. So they use mnemonics, means just way of using. It's like prophase, metaphase, anaphase, telophase. I use PMAT, snare, whatever. But there's different easy ways to remember. This one, you somehow, figure one out. Most of the ones, forgive me, usually are somewhat dirty, as far as I'm going. I'm being politically correct. That's what we did. Humorous and I mean, the trusty truck, who the hell cares? Voila. The volar aspect of the brain. You've seen this before. Here are the pairs of cranial nerves and you saw when we did the brain dissection, and that's why I wanted to frame it, the olfactory bulb and olfactory nerve. That's the only one that enters into the cerebral lobes. It enters by way of the insula. That's why we use smelling salts, because you can arouse that part of the brain very, very quickly. So you weren't there for the dissection, but I'm sure I sent the recording about this type of stuff. You can come in and dissect one if you're feeling frisky. We're doing an eye on Monday. What do you got to do Monday afternoon? Are you busy? When? Oh, you're kidding. Tell them to go be fruitful and multiply with their own kind. Form an anatomically impossible act with themselves. The coach wouldn't appreciate that. Okay. But if you want to do it one day, let me know. I mean, because you're limited with your experience. I don't mean to be limiting, but I mean, it may be fun. We can get some helpers here. They've been there. And then you have the optic chiasm. That goes into the thalamus. Remember those? Basically, that's the second cranial nerve. So basically, smelling salts, why do we use them? Because you can't test the cranial nerves like a la concussion without the person being awake. So the next test, how many fingers? So you're basically, once their eyes are open, you're looking for double vision. You're looking, I can't see any at all. Maybe then you start testing for what are called visual fields. We'll look at that a little bit when we do the eye physiology. That's not this term. That's next term. We'll look at the different visual fields. That's what you test it. It's a chiasm because it crosses over about 90-10. 90% of the fibers from the right eye go to the left eye go to the right. About 10% do not. That affords us what we call stereoscopic vision, basically being able to have depth perception. And my brother-in-law, it's not my brother-in-law, my sister-in-law's husband lost an eye when he was in the Navy. So it effectively, depth, he could always drive and things like that. You learn, it doesn't preclude you from doing tests, but it's the type of thing you can see if he went to a restaurant, he'd always make sure it ranged where the silverware was, the plate was, the glass, so you know where it is. The same thing, you may not be able to read the signs, but you're on a road that you're on a lot. I mean, he worked here at Moon Township for more than 40 years in the water treatment facility. So he was, they live here. So moving on, this is called the oculomotor nerve. That one you probably saw in the dissection. It's thicker than you think. And then you have the trochlear nerve, and then you have the abducens. I'm intentionally skipping the trigeminal for now. So the reason this is important when we do the eye is it controls what are called extraocular eye. You have the eye, science bad artwork. Here you have the nose. There are 6 muscles called the extraocular eye. I'm going to give you a mini mnemonic you will never get this. They're involved cranial nerves 3, 4, and 6. And because of that, they all go through the same opening as you will see, the superior orbital. You have 4 muscles that are straight. The name for muscles that are straight is rectus. This would be superior rectus, lateral rectus, inferior rectus, and medial. Now the next one are obliques. They come at an angle. This is not really how they come, but I'm just looking for. So this would be superior oblique. This would be the inferior. So this is the formula. It looks like you're in chemistry class. It involves solvents. What's the thing we have to do? LR6 SO4 lateral rectus, 6th cranial nerve, superior oblique, 4th cranial nerve, all the rest. You never miss a question, ever. Can I write on the test? If you know how. If you're taking a test like that, write down LR6 SO43. Immediately write down all the list of the cranial nerves that you know. That's what you do. Not rocket science. I'm a good test taker. I knew how to do that stuff. It's an old joke. Okay. It's like, pardon the religious, Jewish men. Oh, what's Murray doing? Oh, he's a sophomore. That was your profession. You're a professional student. I am a professional student. School is my happy place. They offered a retirement package. I want to stay. This is what I like doing. Nobody, I get to tell these same stupid jokes over and over again, the same anecdotes, same war stories, and you're stuck having to listen to them. My wife just looks at me and goes, SDFU. Moving on. So you're going to see these as we come, and then we'll get farther down. I'm saving the trigeminal for this. And if we get through all of it, this is a good chart, but not accurate. 4 of these nerves have what are called parasympathetic function. Until we learn about the autonomic nervous system, suffice it to say that it means it involves glandular structures. Okay, they are nerves, and you should remember this. Nerve 3, you use what 7, 9, and 10. 3, 7. I mean, on a test, I'll have them both. I'm not going to try to play both. Okay, 3, 7, but it's something you should know. 3, 7, 9, and 10. So that PS fibers, you can see it there. So, for instance, the ones that are purely sensory, first 2, olfactory and optic. Where is the error when it says motor function, yes, the sensory function, no? That's the stupidest thing of which I have ever heard. Okay? Because if these control your eye movements, the next cranial nerve, the 3rd, eyes up, eyes left, follow my finger, that thing. Now, if you're looking over there, when Dr. Dress said, what's up, I move my eyes there. I know my eyes are over there. That's proprioceptors. So all of these nerves have proprioceptors. So this is to stick out your tongue. You know when your tongue's sticking out? Shrug your shoulders. You know when you're shrugging your shoulders? Of course you do. So that's why, again, I had this discussion with the A&P classes. Someone who wrote the PowerPoints, this is a classical view of anatomy, not necessarily accurate or clinical. And that's a problem. So smell and vision, self-explanatory. Now, oculomotor, what's the parasympathetic activity? This is the most famous of all the reflexes. So when you see what everybody has in the sideline in that blue tent where you start, they take out pen line. Everybody has, if you're a clinician, you're walking around the floor with a pen line. But you want to be able to test. You bring the light up from here, and what will happen as soon as you shine it, you get the pupillary light reflex. You bring it on this side, pupils, if there's light coming in, they'll constrict. You pull it away, they'll dilate. See, and then do both equal, bilateral, and symmetrical. If it's unequal, concussion. If it's sluggish or overly brisk, really concussion or brain injury. and you eventually you learn what it's in. The other thing you do is called accommodation. You see the tip of you take out the tip of the exam pencil, follow the tip of my pencil, very close to your nose. Your pupil should constrict and point medially. That's called accommodation. You're following it as close to you. That's what these do. That's what this do. And again, we consider all of these at once because what they do. So if I can't move your eyes to this side, I can't move it on. It means the lateral rectus was pull it that way. Weak or is it a spasm? That might tell you something else. What it does is it tells you very well from the level of the fracture. So all of these nerves come out of the superior local fissure. So we know that it could be concussion. Now it could be a fracture in and around the bone that they're associated with. So that's part of what we call the differential diagnosis. We've got a problem here. What does this tell us? And now, what's the next series of tests to figure out exactly what's wrong? That's what, and it's all the time. It's funny because my son called me this morning. He was on his way to Walter Reed. Because of the level he is at and his new posting, they have to do make sure his mental faculties are okay. It's SOP, standard operating procedure. And he said, it sounded to me like they're going to do the same thing. I said, they're going to get there. They're going to tell you an address or something like that. Say, remember that. And go through this whole test and all these different things to do. And at the end, they say, what's the name? What was that address? That's the same thing you do with a concussion. You're basically going to go through a concussion. They're going to do neurological assessment for him to control all the shipping in the Persian Gulf. I guess it's important. I know, you're bragging. He's paying the ass anyway. So that's part of it. Yeah, that was the other. Yeah. And his brother, who's nowhere near the achiever, suddenly he got a pretty good job offer today. So he's pretty. For you folks going into the working world, many of you get the best time to negotiate your salary is when you get a job offer. Once they want you, that's the time to say, yeah, that's not a bad salary, but you do better. I had no idea. I was looking at positions there. That's once they want you, then you have some traction. You have a little leverage. So he's in that phase now. So hopefully it works out. Never can tell. So that's the oculomotor, trochlear, and abducens. That's 3, 4, and 6. They all go through, as you'll see the slides as we go through. So here's olfactory. You saw those. It sits on the cribriform. It enters and exits by way. And this is something I do test you. How does it get in and out? Cribriform plate, ethmoid bone. Okay. Primary olfactory cortex, that's in the cortical area of the brain. Okay. Sensation, you test it with smelling salts, whatever, strongly aromatic substances. So, I mean, and it's something you don't usually see problems. Where do we see problems with that? It was COVID, for some reason, affected taste and smell. And I don't think anybody's 100% sure why that happened. But a lot of people lost that sensation. One of our friends, when he had man older than I am. So, optic nerve is really a tract coming from the brain more than anything else. The chiasm, thalamus. Okay, remember the structure that I asked you about on the practical. Just a reason. Optic canal, sesamoid bone. It's not a facial bone. It's a cranial bone. Okay. They cross over in the optic chiasm, a very important area. And then eventually they get their way to the occipital lobe, purely sensory. And they'll show you that, and we'll go over this. And so blindness, pathways, variety of different effects, clinical testing, you can do this ophthalmoscopes, follow, finger motion, how many fingers, all that type of stuff that you can get into. Oculomotor. So the oculomotor, fairly large. This is superior orbital fissure. And this is the idea, the parasympathetic aspect. It causes what you're going to learn about when we look at the eye called the ciliary muscle or ciliary body. And that's why I'm emphasizing it now. That controls the shape of the lens, and very much, basically, in addition, controls the pupil. Because you're going to see as the pupil constricts, narrows, or widens, it dilates, it also affects, well, the muscle is interesting. It's a circular muscle that imparts a certain amount of this. So it's almost glandular in nature. Obviously, there's, again, proprioceptors, they correct themselves rather than this. And again, using a pen light, etc., like that. And so when they begin to see an eye that rotates laterally, the fancy term, depending on what it is, strabismus can be part of this. Sometimes we'll have a droopy eyelid. That's referred to as ptosis or ptosis. But those are the imbalances I'm not going to ask you about. But to understand, double vision would be something you would find with it. But again, it's not the only one. We get to the trochlear nerve. The trochlear is the only nerve that emanates from the dorsal portion. The oculomotor is from the midbrain. The trochlear is ventral midbrain. This is dorsal, so it goes around. I saw it on a couple of sheep. I haven't seen it on one sheep one recently. And directs, and a primary motor nerve that directs that eyeball. Same area, see? Damage to the trochlear nerve, double vision, impairs, remember what it is, LR6SO4, and it impairs the ability for the work. Because what kind of that oblique does is it pulls the eye down and out, so to speak. So that rotator, so you can take your vision and kind of look down that way. Look down that way. From the angle of it is, and it's too hard, but that's mechanics. Skip that and I'll come back because it's really important to me. To me, it's got to be important to you. So tell Abby when she comes back, it's important to her. Or else. Don't tell Jenna. I just love giving her a hard time. She takes it to heart. And here, and this is lateral rectus. LR6, same opening. So at rest, the eyeball rotates medially because that's paralyzed, or it's just fixed in spasm and rotates laterally, but it points to the lateral rectus. So that's the LR6SO43, which brings us back to, fortunately, the most important nerve to me. This is actually three nerves rolled into one. It's called the trigeminal nerve. Because the gemini are ganglia. And if you remember on the sheep's brain, that big massive tissue on either side of the pons that was thick, that came off when you removed the pituitary and the related soft tissue structures, those were the trigeminal ganglia. We refer to them because the Roman numeral V1, V2, and V3. And you'll see the way they do. These are all sensory. The mixed one is V3. So these are all the sensory from the face. So the illustration is here. So this would be, again, the ophthalmic branch, V1, also goes through the superior orbital fissure, supplies sensation here, both sides of the face. V2, maxillary division, that goes through the foramen rotundum. That. V3, the largest and thickest, all of that sensation, the mandibular division, goes through the foramen ovale. And as well as being sensory, all of those, pain, sharp, dull, and your face is highly sensed. It's highly active sensorium. It supplies the muscles of mastication. I sent you that dictation. I pointed these out. There are four: temporalis, masseter, medial, and lateral pterygoids. So and the way you test it, it's not by moving your finger. It's the ability to move the jaw against resistance. Muscles are strong. I can't force your mouth closed. I can't keep it from opening. I can't. If I try to keep it from closing, you're going to be able to close it. We test muscles against resistance. We grade them, typically 1 through 6. I'm not going to go through that. Muscle testing, but that's the way you test to see if it's intact. And of course, you can test the sensation. I would take a sterile needle, just a needle only, and I'd take it out, and I'd use the sterile end of the needle very delicately to test sharp, and then the hub of the sterile end to test dull. There's other ways you can do it. You have neurological hammers, have stuff that's just a little cleaner technique. Okay, so that's what you're looking at. So this gives you a summary. Here's the bad news. Practically perfect Patty Graves, also known as my wife, has this horrible condition. I wouldn't wish it on anybody. Even somebody I detested, and I don't detest them. Trigeminal neuralgia tic douloureux. Inflammation of the trigeminal nerve, widely considered to produce the most excruciating pain known. And it is. If you know where Costco is up in Granbury, it's on a slow hill. It's the first time I really noticed it. We're leaving the car. She's walking next to me. We're talking, and all of a sudden, and it's very inevitably it's breezier up there than at well, it's just the height. It's a little breezy here. All of a sudden, I look back. She's on the ground. A cane bolt hit her, knocked her right. She had. Are we losing people?
Most of this crew seemed. All right, we're gonna interrupt your cranial nerves for a second.
Go right ahead.
Abigail has something to tell you.
So, have any of the juniors here ever been rough? Beautiful. All right. So there's this program, you may have heard of it before. It's called the Byron Hines program. It's through PIT. But essentially, it is a fully funded summer abroad. You can either do an internship or a study abroad program as long as you meet the requirements here. But it is due November 3rd, so not that much notice. But the application is super easy. Just biographical information and a few short essays. So if you're interested in a free summer abroad scholarship, I recommend. I can also give you guys my email if you have any questions.
9 months to go.
But if you have any questions about the application, need help with the essays, programs, I'm more than okay.
You sit in the exact same seat in my class.
Yeah, you can always tell the back of the room people.
Every class,
They're troublemakers.
We got one.
That trio, they're trouble. Nevertheless, so to continue with this, this is a suicide disease. When was it? Not yesterday or Monday. I went home the whole Monday. I mean, she went upstairs. She was in such pain, either Sunday or Monday, that I could just see it. She had to go upstairs. Right now, because it's flaring, she's in the middle of a steroid dose pack has helped. And it flares, and you can't predict. And effectively, it's not treated. The surgeries are very unsuccessful. You have to go in the base of the skull. There's all sorts of, you can read up on it. This is it. Most stabbing pain, few seconds to a minute, relentless, occurring hundreds of times a day, provoked by sensory stimulus. She couldn't brush her teeth. I mean, we went through a couple of weeks where she couldn't brush her teeth, couldn't swallow. She was very reluctant to go to the hospital. She didn't end up having to go. And I was trying, her daughter was sitting there going, what are you going to do? I said, I'm getting pretty close to the point where I'm going to drag her into the hospital because she was dehydrated. She couldn't take anything, much less soup or anything like that. Clear liquids, a loop of artery or vein that comes thought to. That's code for we don't know. Presses the trigeminal nerve from its exit. Fortunately, there is a nerve, a medicine that works. We do not know why. It's an old seizure medicine called Tegretol, known as carbamazepine. She's on the maximum dose. We've been dealing with this. She was an LPN working for over the last 10 years or so. I suppose an aide and then an LPN at a nursing home. She loved it. Got to the point where she couldn't do it anymore. I mean, you would just flare so much, even though we had that Family Medical Leave Act and all that stuff, with all the provisions. It just got to the point where it was so unpredictable. And so she's on the maximum dose of the Tegretol. She, to some extent, self-titrates. I mean, when it's not bothering her, she doses it down. When it's bothering her, it's the strongest narcotic analgesics do absolutely. It's very unpredictable. We go for periods where it's wonderful, and then other periods. Of late, it's been unfortunately unpleasant. But it comes and goes. That's so. If it's that important to me, you need to know about it. And I say that sincere. I'm not, look, we're doing great. So all of those types of things. Glass nerve, because the other ones are fairly easy. Facial nerve is sort of the opposite, where that's all sensory, with the exception of V3, the mandibular bridge. Facial is all the muscles in your, and I put this on that video or recording I sent to you. The muscles of facial expression effectively are all serviced by the facial nerve. Blinking, winking, smiling, talking, all of that is facial nerve. Okay? And it goes through that stylomastoid foramen. Remember, because you had the mastoid process, he asked you about. Styloid process, he asked you about. There's a little opening in there right by the temporomandibular joint where that comes out. That's why sometimes impacted by TMJ. In classic, and it has parasympathetic function, tearing salivary glands are involved. So sometimes you will see inappropriate tearing or some aspects of salivary gland function. It's one of those little, let you know. The big deal is your tongue is divided. So you have, think of it as cranial and facial. The facial portion of your tongue, interior 2/3, is serviced by the facial nerve. Sort of the throat portion of your tongue, not so much cranial, but think throat, is serviced by the 9th cranial nerve. Okay, you're going to see we'll call the glossopharyngeal, which actually means throat and tongue. So sensory, special sense of taste, and that's where most of our tasting is done. To be very honest with you. Stylomastoid foramen. This is very interesting. So this is basically enters the temporal bone and then runs within that diurnal acoustic meatus, and then exit by way of the stylomastoid foramen. It's mixed because you have sensory and motor, all of those things. I mean, it's easy to test. You can do taste sensation of the tongue. But here, the big player here, and you probably know somebody with Bell's palsy. We don't know what causes it. You can get it after a cold, you get it after trauma, tumors, infections. It's hard to predict. Typically, it goes away, and you would probably see it's like a facial droop. One side of their face, they'll have an eyelid will droop. This stuff will come out. It's like you went to the dentist and they numb that side of your teeth and you had stuff coming out. That's what it looks like. Rapidly, inflammation, swollen nerve, herpes simplex is certainly implicated. Lower eyelid droops, corner of the mouth sags, etc., etc. Okay, most of the time you can treat it. Complete recovery, 70% of the cases. My late former brother-in-law had that. He was in a high-stress job. He was a 9/11 operator for here in the city of Pittsburgh. We don't know if that was it. Unfortunately, he had an alcohol problem, so maybe that impacted it. That's when I basically met him. And that's when I met the late Dr. Jerry Rabinowitz, who was one of the ones who was assassinated at the Tree of Life incident, who I had gone to high school with. So, I mean, interestingly aside, one of my mentors had this permanently. Now, about 20, 25 years older than I. I think he may still be around now, close, probably late 90s. But he had permanent droop here. So most of the time it resolves. You're going to know somebody with it. It happens. It could happen to you. Most of the time it responds nicely. You're stopping. Thank you.